who joins us actually from the States, so San Diego. So that absolutely is flexible working. David is the VCHA regional lead for the north of England, with 34 years of army service and a significant work in local government. David brings a deep expertise in the Armed Forces Covenant delivery and continuous quality improvement. David, over to you. Hopefully you can hear me.
Guy, yes, thank you. Thank you. Good morning, indeed, from San Diego. Ladies and gentlemen, it's really good to be able to present on this piece of work, and it's been great listening to the presentations this morning, and I think the flow is going to continue. This presentation is on continued quality improvement, and this is really about looking how the programme now starts to drive forward following our full accreditation. First slide, please. And next slide. We've heard that Veteran Aware is an NHS national clinically led health quality improvement programme. It's premised on an 8-point framework that offers a holistic approach to delivering Veteran Aware in NHS trusts and other health settings. Since the publication of the CHVAS report in 2014 and the creation of the Veterans Covenant Healthcare Alliance, the programme has steadily evolved through a series of phases which typically advance through increasing levels of maturity as that cycle progresses. Through learning, experience and other factors that are built into the cycle or that develop as it evolves, this enhances the ability to better inform the process and the impact that it has. As the experience level grows, it can be applied to support further informed enhancements of the programme. Understanding the intended effect also enables improvements of the individual elements of the framework and their collective interaction. The 8 Veteran Aware standards effectively comprise of 6 enablers: governance, training, links, referrals, communication and employment, that inform and ensure an improved patient experience is the outcome, along with meeting the NHS commitment to the Armed Forces Covenant. Next slide, please. In this presentation, we will explore the maturing of Veteran Aware and how this has helped to form a continued quality improvement process to support health organisations following achievement of all NHS trusts accredited as Veteran Aware and other healthcare providers now included. Scope will cover some background, a look at the context of how it's applied, the evolution and maturing of the programme, the production of the CQI process itself, and a little bit on the impact. Next slide, please. We start by going back to the early days of inception when the steering group were delivering the first accreditations and the beginnings of the framework from 2018 were applied at a basic level. The first significant step in the programme is the addition of the regional lead team in 2021 that led to the production of the initial question set and direct support to organisations that sees the level developing. This development period is for both the organisation's understanding and implementing Veteran Aware and the evolution of the regional lead teams in how we deliver support. And from 2022, better informed application of the question set sees improved accreditation quality and also the commencement of reviews and reaccreditations. The inclusion of the rehab and data projects provided further opportunities to expand and share engagement learning across all trusts and wider into health, incorporating the independents, hospices and care homes that are now included in Veteran Aware and the veteran friendly framework. The main effort throughout had been to accredit all NHS trusts, and with improved engagement practices and a resource repository populated with products created by trusts such as network terms of reference, policies, templates for patient engagement practices, data capture, accreditation quality continued to grow. The concept of shifting from an accreditation awarding body to an assurance-focused approach is applied as pace to full accreditation quickened, and the main effort began to switch to enduring support as the baseline was accomplished. The context of these factors and a range of considerations must be noted, and how this next evolution sets excellent conditions for the new National Healthcare Training and Education offer. Next slide, please. All progress since 2018 has been achieved against a backdrop of a busy NHS, compounded by a pandemic and unprecedented challenges that altered traditional pressure points in the calendar that impacted on the capacity of organisations and staff to engage to become veteran aware. The individual nature, size and type of each organisation, a starting point that spans 7 years, appointing appropriate leads, establishing teams, funded versus unfunded roles, protected time, or fitting veteran aware around core roles, myriad patient systems, or introducing new EPRs, and attempting to standardise an armed forces data field into such a complex scenario. How to ask the question and adapt the framework around organisational operating procedures are all considerations that have informed our understanding of how best to support, to utilise internal expertise to help better understand the armed forces community. This has helped us to build on the baseline through the future phases of implement, embed and demonstrate, with embedding being the main driver for veteran aware to endure. Next slide, please. Here we see that journey from those early accreditations, the evolution from introducing regional leads and improvements to the maturing of veteran aware and the developing quality of individual programs. The shift continues quality improvement alongside the new National Armed Forces Healthcare Training and Education Programme, updates the conditions that will enable regional leads to improve the support of embedding veteran aware. Next slide, please. The start point for producing the CQI process was to conduct an analysis of each trust progress through accreditation, review and re-accreditation, noting that some will have been subject to early accreditation against a less developed framework and review processes, whereas those accrediting more recently will have had the developed question set applied, but not have completed review or re-accreditation yet. What we have developed is a CQI matrix that takes the baseline of accreditation whenever it was achieved and interrogates the detail within each standard to help healthcare providers cultivate not just the activity that develops progress in each standard, but also supports their collective application. It is acknowledged that the desired improvements will take time to achieve given the factors and considerations presented. The matrix provides a means to conduct more detailed gap analysis that informs intent and action plans. And in initial practice, it is supporting early preparation and planning for future reviews and reaccreditations, which help support the capacity challenge. Next slide, please. To illustrate how this works, here is the CQI model applied to Standard 3. Identify members of the armed forces community and how it progresses through the implement, embed and demonstrate phases, which are grouped into time bands that reflect different points where any individual organisation might be in their journey. Some are already at or close to the embedding phase, whereas others, for reasons pertinent to individual organisation context, will take more time. The net result is that all will have the same approach applied that will over time reduce the unwarranted variation in programmes and regulate the quality level. The phase takes the baseline of having an armed forces field within its PAS or EPR as the premise to accredit. Next slide, please. To implement, we need to determine how effective data collection is through the conduct of an evaluation of application and staff engagement with patients and recording armed force status across all clinical services and relevant entry points, ensuring an understanding by staff of what asking the question means. Next slide, please. Consistent data collection across all clinical areas enables analysis of impact, which in turn provides learning opportunities from evidence-based outcomes and measures and improvements in reporting. Next slide, please. The evaluation of the identified standard has the potential to not only improve data collection and reporting, but also to inform how CQI benefits the other standards. Next slide, please. Improved data reporting integrates veteran-aware governance into organisational governance. It informs training requirements where less developed clinical areas or services are identified and can be targeted. It helps develop clarity in messaging for internal communications and promoting organisational commitment to communities. Enhancing partnership working, it strengthens relationships with local and regional support services, local military units, neighbouring health providers, all which reinforces the collaborative system effect expected of integrated care boards, which will improve referral pathways. And for the workforce, it is able to exploit the experience and expertise of existing staff in understanding the military community, the importance of asking the question and recording, which exposes the forces-friendly nature of the NHS as an employer and a care provider. Next slide, please. In summary then, the impact of continued quality improvement is already evident, albeit in pockets of best practice within some trusts and other health providers. But it is this that provides the opening to accelerate the effect and maturity of veteran aware through this next cycle of the programme's evolution. Good data is already demonstrating that where armed forces patients are effectively and consistently identified and supported within a system, the benefits expected in the earlier phases of the organisation and the patient have materialised. Most notable are financial and bed hour savings. Continued quality improvement applied alongside the new training and education programme will support individual veteran-aware programmes, as well as group and ICB efforts in providing healthcare to the armed forces community. Continued quality improvement presents an opportunity through Veteran Aware for quantitative and qualitative data on the military community to be collected and analysed on a national level that has never existed previously, and bring further improvements to the healthcare provision for the armed forces community and continuing to raise the bar higher. Thank you.
Great, thanks very much, David. That is a critical piece of work, actually, in terms of embedding what we are absolutely doing now. So moving the dial forward. And of course, a big shout out to the trusts who are under considerable pressures, but are absolutely engaging in this process. So thanks very much, David. It links absolutely into the NHS 10-year plan as well, which is important. Have a good sort of leave, David, and thank you very much for joining us from the States, and see you at the end of September. I think you're due back.
Thank you.
Great, thanks, David. Right, we're now going to sort of move on. Really, you've got me to bang on for the next sort of 10 minutes. So I'm going to give you a little bit on the Armed Forces Healthcare Training and Education Programme. Next slide, please, Anna-Marie. Next slide. So this is what I'm hoping to cover, really, bit of background and context, and I'm conscious that Kate and Tim have stolen a few of my sandwiches. Bit on the aim and objectives, bit on the rollout plan and delivery model as well, and linking that to training objectives and indeed the training modules as well. And then critical, really, I suppose, is the outcomes, and really a call to arms or call to action at the end of it. Next slide, please, Anna-Marie. So that was the background. So a lot of evaluation just come to fruition, which was led by the Armed Forces team at NHS England, in terms of the advocate programme, socialist prescribing, and the Op Community Pathfinder. And the key element, in fact, the key thread through them programmes evaluation was that how can we expect the workforce to know what to do when they're not trained and educated? So that was really important, and I think was probably a turning point. I think it's worth mentioning that this work is absolutely supported by Nicky Murdoch and the Armed Forces Patient and Public Voice Group, and indeed the Clinical Reference Group, and them two areas are critical to this programme, in fact, to armed forces healthcare in general. So absolutely critical. But I suppose it was on the back end of every trust signing the Armed Forces Covenant, which was a major achievement, that we managed to get Amanda Pritchard, next slide please, Anna-Marie, to visit Royal Hospital Chelsea, as Tim alluded to. She reaffirmed her commitment to the armed forces community. She took talks with Kate Davis to a number of veterans in Royal Hospital Chelsea, and as she was walking out the door, she said, we must do more. And that was also a catalyst for that moving to the next stage. And so Deborah Elliott, Director of Transformation in the Armed Forces team, managed to secure funding to link into that training and education piece. So again, a pivotal moment, really. And it was a really short flash to bang time, actually. So yeah, big shout out to Deborah, who I'm working really closely with at the moment. Next slide, please, Anna-Marie. So this is sort of the aim of the programme. Please don't sweat all that detail, but it's about developing the skilled education and inclusive primary, community and secondary care workforce, and that absolutely links into the workforce plan, actually. So doing professional development, and this is sort of critical going forward. Next slide please, Anna-Marie. So you've sort of heard the objectives, but just to reiterate, it is about health inequalities, it is about unwarranted variation, and it is about disadvantage. And of course, it's right across that armed forces community. That's the key thing. The other thing as well is trying to increase awareness of the unique characteristics of this community, and all linked into, you know, statutory responsibilities. And I put them in that order specifically because, you know, in my view, to win a clinician over, you talk about health inequalities. You don't wrap them across the knuckles about statutory duties. Every trust has huge amounts of statutory duties. So that is really important to hoist in. Next slide, please, Anna-Marie. So in terms of the rollout plan, you know, what is the audience? Well, number of cohorts. You wouldn't be surprised to know that it's across the system. So it's going to be NHS / DHSC, and obviously they are combining over the next sort of year or so. Integrated care boards, and again, they're going through a major reorganisation. Clearly, secondary care and indeed primary and community care. So they are the key sort of cohorts, but I do feel there might be other opportunities. But at the moment, in scope are them cohorts 1 to 4. Next slide, please, Anna-Marie. So here's the delivery model. And again, I just want to put this into context. There's 1.3 million people in the NHS. So we're asking an awful lot, A, of the NHS, and B, the training team themselves. But, you know, I see this as a flexible approach, you know, face-to-face virtual. There will be e-learning. There'll be induction videos. There'll be a train-the-trainer package. And of course, we'll be providing sort of digital material as well in terms of resource. So again, they are the 5 delivery methods. Next slide, please, Anna-Marie. These are the broad training objectives, which were agreed at the highest level. Kate Davis assures me, I think she mentioned even at government level, if I'm honest. But the first one, obviously, is to comply with the covenant duty and consider due regard. And again, I just want to shout out maybe some of the terms haven't been used in this specific audience. We talk about the cohort of the armed forces community, but I also want to include the bereaved and those that are injured and sick, because there are a few of them. So that is really important, that inclusivity. Training objective 2, we've got to be able to identify this community, and that links into the Ask campaign and identification. Once we've identified them, we can deliver that personalised care. And of course, the big one is leading to improved outcomes for the armed force community, NHS staff, and, you know, service leavers as well. And that is really important. So next slide, please, Anna-Marie. So these are the 5 modules, again, agreed at the highest level. Module 1 is an introduction video, which will probably be released around the October time. Module 2 is a leadership overview, strategic. Module 3 is probably where the rubber hits the road, if I'm honest, will be that workforce module. And module 4 will be e-learning. And again, we're working on a package there. And of course, more importantly, we're going to leave a train-the-trainer package. So we're going to hand responsibility over to armed forces leads, armed forces champions within organisations. But of course, we are there to support. So that is really important to hoist in. Next slide, please, Anna-Marie. So it won't surprise you to hear that we've conducted a number of focus groups. So the material has been co-produced. And I have to say, actually, I've been under a bit of pressure and scrutiny, again, at the highest level and from some big hitters. But I think I just wanted to share with you that, you know, this is a team sport. And so I've presented, or my team have presented to senior management team and chairs in the armed forces team. We've presented to the clinical reference group. We've presented the armed forces patient public voice group. We've presented to Chair Gerft, Tim Briggs, and of course a number of NHS trusts. And what actually has impressed me is the quality of the feedback. It's been measured, proactive, supportive and positive. And that has been sort of enlightening, if I'm honest. But I think the key thing is that, you know, of them 205 odd trusts, 71 trusts have actually engaged in this process, which is brilliant. And on the right of the slide, you can see by region, you know, that trust engagement. So again, a shout out to all those who supported the focus groups. It's been a hard slog, hard fought yards actually, but we are almost there. And the other thing as well is that we've conducted a number of you spoke, we listened workshops as well. And again, it wouldn't surprise you that, you know, we've involved the Armed Forces senior management team, the Armed Forces Patient Public Voice Group and various trusts. And we are almost there. So real co-production. Next slide, please, Anna-Marie. I think in terms of outcomes, obviously, you know, one of the key things is raising awareness. And again, I think Tim mentioned it. What we're doing for the armed force community will raise standards for everyone in the NHS. And I think that's the smart bit of this programme. It really is. But I think in terms of them outcomes, again, strategy, it links into the 10-year plan that Kate mentioned. It's about confidence in practice and that personalised care. So staff know how to deal with this unique cohort. Connection to the third sector, absolutely critical. And I know it's called the third sector. I think it's probably called the essential sector, actually. So a big shout out to everyone out there, our partners. Access to learning links into that workforce plan, right? We improve the workforce. And if we improve them and do professional development, they'll stay with us longer. And that is really important. And I suppose the critical element to the outcomes is about reducing them inequalities and improving that patient experience. So it's going to be, you know, a challenge, but the training team are absolutely up for this. Morale is very high. They cannot wait to get out there and deliver stuff. Next slide, please, Anna-Marie. Again, I just wanted to give you a feel for engagement across the trust. And I know that the trusts are under the cosh, operational pressures all the time, you know, strikes, you know, a new variant of COVID. I mean, it's huge challenges and, of course, a reorganisation. I mean, you couldn't write all this stuff, right? But what has really impressed me, and the green bar along the bottom, is when we sent out an initial email to trust chief execs, all 205 of them, the response rate has been absolutely huge, 82%. Now, if you look at that in engagement terms, I'll be honest, generally you'd get a 5% return, but we've had 82% trusts. And that will be for various reasons. It will be the armed forces team continuing to drive that agenda. It will be about the VCHA team. It'll be about the ops suites. It'll be about the GP scheme. It will be about the third sector. So, you know, absolutely huge response. In addition, we had some sort of draft surveys. And again, I'm staggered, you know, half of them trusts have responded, which is absolutely incredible. So I get a real warm feeling about this, you know, and I know we can absolutely deliver this, but it is a team sport. Next slide, please, Anna-Marie. I thought I'd just give you a bit on the programme timelines. I've never seen the NHS work so quick. And again, I think it links back to Deborah Elliott driving this programme right at the top with Kate Davis, getting the funding last November. We recruited a team in March, again, a mix of veterans and healthcare professionals, all very professional. You know, they make me look really good, which is great. April and May really was about induction and orientation. May was the programme concept. And really sort of June, we've done module production. And then, of course, July, we've done the stakeholder engagement focus groups, again, which has gone down really well. And at the moment, August, September, we are in the review and refine modules. And again, you know, Kate Davis sat through the modules last week. In fact, actually, I think it was Monday, wasn't it? Monday. Hugely impressed. with what the team had produced, but it was co-produced, and that is the critical thing here. And I mentioned the 5 modules. Modules 1, the induction; module 2, the strategic or leadership; module 3, the workforce, have almost been signed off. In fact, modules 1 and 2 have been signed off. Module 3, a little bit of fine tuning, but we are ready to rock and roll. So in October, there will be a soft launch. And then in November, I'm going to set the team free, and they will start doing operational delivery. And already trusts have booked in training sessions. And again, that really heartens me. I'm actually hugely humbled by people absolutely leaning into this program. Next slide, please, Anna-Marie. So hopefully that update was useful. I'll obviously be around at the end if anyone's got any questions on it. But from now, from me, I'll say goodbye. However, I want to introduce the next speaker, really, is Dr. Mary Keeling, who is from the Research and Development, referred to as RAND Europe, actually. And Mary is the Deputy Director of the Centre for Evidence for the Armed Forces Community. And Mary has been leading research into military health since 2010, with a focus on the psychological impact of service on personnel and families. Mary, over to you. Hello, Mary.
Sorry, apologies for the delay. I was just trying to get the right background up. So
not a problem, Mary, not a problem. Right, I'll hand over to you now, Mary. Cheers.
Great, thank you very much. Sorry, just 1 second. We're early, aren't we? And I was a little bit caught off guard, so apologies. So yeah, so hi everybody, I'm Mary Keeling. I'm the Deputy Director of the Centre for Evidence for the Armed Forces Community, which is the main role that I undertake in my role as research leader at RAND Europe. So I'm speaking to you today as the Deputy Director of the Centre for Evidence for the Armed Forces Community. So the centre is funded by the Forces in Mind Trust, and we have been running this since 2022 as a collaboration between RAND Europe and the King Centre for Military Health Research. And the centre has actually been existing since 2017 and was previously under the guise of the Veterans and Families Research Hub, then the FIMP Research Centre, and we recently changed the name earlier this year to the Centre for Evidence to hopefully better reflect what it is that we do as the centre. Next slide, please. Oh, sorry, and the slide after that as well. Thank you very much. So this is just a quick overview of the team so you can get a feel for who we are. So we have our co-directors, our governance advisors, obviously me, Kirsty, the deputy, and then we have a team of postdoctoral researchers and junior researchers as well. Next slide, please. So I was pleased to see the theme of the conference being raising the bar higher, and it really fits with what we're about as a centre, in that we really are working towards raising the bar higher for the armed forces community, but with a real focus on the importance of evidence-informed decision making. Next slide, please. And so the vision and mission of the centre really reflect how we fit with the conference theme. So the vision, which I think is probably shared by everybody on this call, is that there should be a thriving armed forces community. And the way that we work towards that specifically at the centre is by putting evidence at the heart of decision making to enable a thriving armed forces community. There's 2 parts for how we work towards doing that. The first is providing the evidence, and the second is around connecting and equipping all to use that evidence. Next slide, please. Oh, I think my slides were changed and the background was changed, so you can't see the text because I actually have a lot of white text on what was previously a black background, so apologies, these slides might appear a little bit funky. So firstly, talking about providing the evidence. So we do this via various mechanisms. Some of the big ones of that, and most of this is through our website. And you'll see I've put QR codes on some of these slides. So if you want to navigate to the website, if you're not already familiar to it, you can use the QR codes to do so. So we have an online repository of research evidence. So as you can see from the little video here, this is searchable by keywords, country, theme, authors, and the type of resource that's available. We update this every month by doing a thorough search of the international literature, and then we update all new recently published research papers, whether that be journal articles, grey literature, and also policy documents into this, with an average of about 200 new papers being added to the repository each month. And so this is, if you want to go to the source of evidence, this is where you can go and search it and find it. Next slide, please. However, we know that not everybody has the time to be going to original research papers or the capacity or knowledge in terms of how to sort of read, digest and use those. And so we also do things to take the existing research evidence and provide it in more digestible and easy to use formats. One of those ways is through the various regular news articles that we produce. So, for example, we produce news features where we identify an important area that's topical at the point in time, and we then essentially do sort of a quick evidence review and then write a sort of news style article about it. So, for example, in the past, we have done an article around eating disorders in the military, which is a overlooked area in much of research and from our understanding in service provision. And so we drew attention to the fact that actually, if we look to US and Canadian and other Five Eyes countries research, there is emerging evidence for an increased prevalence and risk of eating disorders within the military population, including serving personnel, veterans and families, but yet actually we don't have a lot of evidence and understanding from the UK. And so that news feature just really highlighted that gap, and hopefully will start to make momentum for more attention to be paid in that area. We've also written one on chronic pain, which is topical to what Tim Briggs was saying earlier, and you can find that on the website. We also produce research spotlight articles, and this is where we identify a recently published piece of research which we believe to be of good quality and to should be impactful. And we ask the lead authors to write a summary of their research paper in lay terms so that people who wouldn't normally read an actual research paper will instead read that and be able to use the evidence in their work. We also do meet the expert interviews where we talk to an expert in the field, whether that be a researcher, a service provider, a commissioner, policymaker, etc., but key people across the armed forces sector, and we interview them. And really this is about raising awareness about who's who. If we want evidence to be used, we need to be connecting the dots between who produces the evidence and who uses the evidence, and these meet the experts interviews are one way in which we do that. And then lastly, in terms of news, we do a news study spotlight. So when a new piece of research has been either commissioned or provided funding and is just got going, we ask the researchers to do an interview with us where, again, it's just raising awareness of why the research is being conducted, what's the aims and the predicted outcomes of the project, and how the study will be conducted. And the point of this is to make sure that people are aware of what research is happening right now, so we know what evidence is coming in the pipeline. Next slide, please. Thank you. So another way that we provide available evidence in digestible and usable ways is we produce research and policy summaries. The centre is organised across these 9 thematic areas, which are kind of considered as core transition outcome areas. So education, employment, family and relationships, finance, housing, the justice system, physical health, mental health and well-being. To date, we have produced these summaries for the justice system, for post-service employment and on post-service housing, and we're currently producing them on finance. These take us a little bit longer than the news features because they follow a very robust systematic literature review process where we review all existing research evidence that's UK-centric on each of these thematic areas. We read it, we digest it, and then we write it in a lay summary. So we do all the sort of hard work so you guys don't have to. And then we do the same for policy, and this includes doing stakeholder interviews as well, so we can understand what is the current policy that exists across these different areas, what evaluations have happened of existing services and what existing services exist. Thank you. Next slide, please. The other way that we provide evidence, and this also sort of tips over into the connecting as well, is that we have an annual conference. This is happening in May next year in London. And at the conference, the idea is to bring together people from across the sector to share recent research evidence, but also to provide space for people to meet and connect. And hopefully this might lead to future collaborations and more joined up working, as well as providing the evidence. Next slide, please. So that's meant to say connecting and equipping. So next slide, please. So now moving on to the things that we do, which are around how we connect and equip people to use the evidence. So one of the key things here is that we provide some research directories. Essentially, it's a who's who and a who is doing what across the UK in research. So the ongoing research page is a list of, or a searchable directory instead, in fact it's more than a list, of what research is currently being conducted in the UK with the armed forces community. You can search that by theme, by method and by keyword. So if you're interested in what evidence is in the pipeline, or if you're thinking about doing some research and you want to know what's currently happening, you can go and search on there and find out what research is happening. The research community page is a directory of researchers in the field. So if you're looking for an expert in a particular area, for whatever reason, whether to collaborate or to seek information on a particular area, you can go on the research community page, and you can also search that by thematic area. Next slide, please. Thank you. So the next thing is that we produce resources. This is a growing body of resources and documents which aim to equip people with a greater understanding of evidence and how to use it, essentially. So, and also it's for researchers as well as it is for non-researchers. So far we have produced an article which provides a method around how we update our repository, just to give full transparency about the robust process that we use to update the repository, so you can be assured that it's a useful and comprehensive resource. We've also created a resource of more targeted at researchers, but also commissioners of research, but also, I mean, more widely than that, but it's a guidance for how to conduct inclusive and equitable research. And we recently published a research jargon buster as well, so to help people understand terms that academics and researchers we just throw around, but actually forgetting that not everybody understands what we're talking about. So we hope that that's a useful resource for people. And we're adding and growing to this list of resources regularly. Next slide, please. And then the last thing in terms of connecting and equipping is that we meet with people and we provide advice. We regularly meet with these organisations that are listed and also many others, the Devolved Nations commissioners, smaller and larger organisations, and we meet to make sure we're all up to date on what each other are doing, sharing ideas, and make sure that we're joining up and working collaboratively, but also we provide advice, whether that be to organisations or individuals. So for example, people who are conducting research, if they're having difficulties recruiting participants, we can provide advice in how to approach that. Or if people want to understand, maybe they want to partner with somebody to do some research, we can suggest people to partner with and make connections. If people are interested in understanding research gaps, we can have conversations about that, and just generally anything to do with research as it relates, research and evidence as it relates to the armed forces community. The one thing that I've not mentioned, and I forgot to add the slide in, is that we also do our own primary research, and we've actually just completed a piece of research which is looking at the perceived benefits of service, and we're releasing the results of that next week. And so we identified a gap in existing research, was that whilst we focus a lot of our research around understanding the challenges and how to support those challenges, we kind of know less about what are actually the benefits of having served, which is also important for us to know. And so yes, next week we'll be releasing the results from that important research, so stay tuned. Next slide, please. I don't know. Oh, you can see it. Oh, good. So these are the various ways that you can get in touch and connect with us. So the website is where we have most of our outputs. You can sign up to our monthly newsletter. You can email us about anything to do with research, evidence and the armed forces, and you can follow us on LinkedIn. So thank you very much. That's all from me.
Great, Mary. No, thank you very much. Really insightful. And, you know, that term about evidence-based decision making is absolutely critical to going forward. So I'll now hand you over to the Armed Forces Covenant Trust Fund and Claire Rick. She's the Interim Director of Strategy at the Armed Forces Covenant Fund Trust. And Claire leads on policy, strategy and impact, ensuring the trust delivers meaningful change for all of the armed forces community. Over to you, Claire.
Thanks very much, and thank you for inviting us to come and tell you a little bit about the Covenant Fund. It's really nice to be here, and isn't it horrific to see how your hair colour changes across these different profile pictures that get shared. But moving on from that, so next slide please, and probably to the next one as well. Thank you. So yeah, just to cover the kind of fundamentals first for anyone who doesn't know that much about us. We're a national funder created in 2018 as both a charity and one of MOD's non-departmental public bodies. We distribute the £10 million annual Covenant Fund on behalf of MOD, but also other funds on behalf of the department and on behalf of the Office for Veterans Affairs, for Treasury, including funds like the Armed Forces Families Fund, the Veterans Capital Housing Programme Fund and the Veterans Mental Health and Wellbeing Programme, just to give you a few examples. We are sometimes confused with the Armed Forces Covenant team. That's not us, but we do work very, very closely with them. And just one of the sort of big differences, I guess, to flag between us and other funders out there is that we fund projects, not organisations, but we'll come on to that in a minute. Next slide, please. So just to sort of give you a bit of a sense of our vision, and as Mary said, actually very much shared vision this, isn't it, across really everybody who's speaking today. Our grant making strategy is informed by MOD's strategies, including the Armed Forces Covenant duty itself, of course, but also the family strategy and the veterans strategy, for example. And our remit is set through public frameworks from MOD every 3 years. You can read those online if you're really interested, but in a nutshell, the Covenant Fund is there to kind of help delivery of the Covenant where statutory services can't reach or can't go, and I'll give you lots of examples of that as we go through. Next slide, please. I mentioned our grant making strategy, so we work on a 3-year basis, and this is the current one, which runs to March 27. That was built through detailed review of evidence and policy to determine the kind of gaps and the needs for those in the armed forces community, which aren't being or can't be met through statutory support alone. So it's that bridging between statutory services and the amazing work that's done by the third sector and others. We also used focus groups with organisations and stakeholders from right across the sector to build this strategy, and a big survey which anyone in the community could look to answer. We have more than 500 responses. And the 3 kind of big goals for this cycle were around improving mental health for veterans, reducing isolation and loneliness across the community, and reducing the impacts of stress and challenge for forces families. They were the priorities that the sector gave us, basically. And the blue boxes here show you how different funding programmes within the Covenant Fund are responding to those areas during this cycle. We made the first grants over the course of the 24-25 financial year, and I'll show you what they look like in a minute. But working in this way fundamentally is allowing us to kind of shift our focus to more longer term grants, and that really sort of transformational work that we know is needed. Next slide, please, which just kind of isolates those top line outcomes again. Next slide, please. So every funding programme we design starts with evidence of need. So that's where actually we seek to work really closely with partners like the Centre for Evidence and Mary's team, so that we're getting that sense of where the evidence gaps and the priority needs are. We're talking to those with lived experiences and those who provide support to them. Our team works with universities and other specialist research organisations as well to make sure that our work is drawing from and helping to build that national evidence base on needs of everybody in the community. And this move to a 3-year funding cycle is allowing us to collect and learn from impact data more consistently right across all the projects we fund, and to be able to share that learning with an even wider base. So we're looking to get that learning out there, not just with our government partners, but with other funders and anyone wanting to build their knowledge of how to support the community. Next slide, please. So this is just a little snapshot of our work so far. So lots of the programmes that we've funded through different funds on there. Next slide, please. We have since 2018 managed well over 160 million in grants across all the different funds that we've looked after. We've had almost 7,000 applications and we've made almost 3,000 awards. Next slide, please. This just gives you a sense of how that funding spreads across the UK. Some grants do operate UK-wide, others are supporting forces families overseas. Funded projects themselves, their estimate is that almost 4 million people have been reached by those grants over that time. And in terms of decision making, those decisions are made by our Board of Trustees. That's made up of 7 representatives that are nominated by government and the devolved administrations. 6 of our independent trustees are appointed by the Secretary of State under the public appointments process. 1 is nominated by the chair of COBSIO and 1 is nominated by any one of the family federations in turn. So that rotates. Next slide, please. This just gives you a sense, hopefully, of the different organisations, the kind of range of organisations that get funded through our work. You'll see there NHS organisations among them. Really useful snapshot, I think, of the breadth and depth of the sorts of projects and partnerships. It's those sort of collaborations really that come screaming through to you. And of course, we expect to see that broaden again as the planned expansion of the legal duty rolls out. Next slide, please. So this was what year 1 of that 3-year cycle looked like. So this was for the financial year running to March 25. You can see there 114 grants made, and that was where the spend landed. And we just move to the next slide, please. Every programme we design has a theory of change, which is a model that I know lots of you will be familiar with. And of course, that's all about the kind of outcomes end of it. And these are the top 10 outcomes by spend across all of the Covenant Funds programmes last year. I'm just showing you because with a sort of healthcare eye, it is really good to see that the top 3 by spend there are all around enabling that better health and well-being, very especially focusing on the mental health aspects, which we know are obviously a contributor to all sorts of the pressures and challenges facing the NHS. And that was the top priority for the community during our consultation for this strategy. Next slide, please. Just most importantly of all, I guess, this is the sort of 24-25 years snapshot of the people being reached by grants made over that period. I just sort of always highlight really the kind of ripple effects of those who are indirectly benefiting from grants like this. You know, it's kind of easy to forget that indirect group, but these will be the families and carers and the support network of those directly affected by an issue. And actually the change for them can often be as impactful and isn't always recognised. So that's another reason why we're so keen to be maximising the potential for learning and impact data and getting that evidence out so we can build understanding of what more needs to be done and what really works. Next slide, please. So just a few examples in these last few slides of some projects that have had a real health and care leaning in their focus and where we know the learning will sort of help to change and inform the way armed forces people are supported. I could have picked, there are so many projects I could have picked to profile here. I've just picked 4. So next slide, please. So this one hopefully will be familiar to some of you. This is a project we funded together with NHS Improvement back in 2021. This was a £2 million grant to test the concept of an advocacy role for veterans in acute hospital trusts across the UK. On the screen here, hopefully you can see it is a bit small. There's a sort of snapshot of the trusts that were involved with that project. There was no template for how to do it. Each trust which secured a grant developed its own approach to that brief. And in Northern Ireland, actually to say, there was a slightly different approach which responded to the needs and solutions that were needed there, with alignment with an award to the Veterans Support Office, which established an out of hours help and advice line for statutory professionals working with veterans. But at their core, all of these roles were around improving identification of veterans in hospital, giving them tailored support, and helping to coordinate between hospitals and specialist charities and organisations who might help that patient as they leave hospital and continue their recovery back at home. There's a fantastic evaluation by the team at the University of Chester's Westminster Centre for Research in Veterans. Definitely worth a read if you want to understand the programme in the round. Next slide, please. On the screen here are just a few snapshots from that evaluation. You can see how the roles sort of raised awareness of the needs of veterans among hospital teams and improved experiences in hospital. Some projects were able to show more cost-effective ways of providing support to veterans during their stays in hospital, reducing the length of time they were there, and improving that access to support within the wider local community. And in Northern Ireland, just to flag, the helpline took calls from veterans themselves, statutory and non-statutory organisations. In fact, veterans themselves made up 44% of callers. So really interesting that, demonstration of how veterans will access that sort of support when it's available. And the service played a role in kind of getting help to veterans who may have been previously harder to reach. And in that evaluation, 79% of respondents reported that the advice line had led to a positive impact on their well-being, and analysis of the nature of those queries is informing ongoing work to better support veterans in Northern Ireland. As you can see in the training outcomes as well, these advocate roles have worked to build awareness and skills and culture around supporting veterans in healthcare, all informing lots of the work that's happened subsequently. So so really great to see. Next slide, please. Different project just to highlight. Hopefully some of you will be aware of the Thrive Together network of charities, organisations and agencies all working together to enable easy access to mental health and wellbeing support for veterans all over the UK, and also looking at physical health and the health of families. This network was born out of Treasury's £10 million Veterans Health and Wellbeing Programme announced back in 2018. That was all about improving mental health through places of safety and effective pathways of support and access to training for volunteers and staff. And that network has really been a catalyst to bring together more than 500 organisations and agencies, funded and not funded, to reach an estimated 12,000 veterans with mental health and wellbeing support, and an estimated 54,000 beneficiaries in total so far, which is just incredible. The first 2 years of the programme, when it was catchily titled VCHA, saw the involvement of 25 NHS organisations, so all working with charities in their areas and other local organisations around that kind of shared vision that there is no wrong door for veterans' mental health. And the final evaluation of those first 2 years shows that all regions across the UK reported significant progress in those routes to support and referral mechanisms. All reported that their regional network had positively impacted how they approached and supported veterans with mental health needs. Partners expected to see an increase in referrals from GPs to mental health services, a measurable decrease in the number of veteran suicides or incidences of self-harm, and an overall improvement in their confidence and their ability to seek help. And this work is all ongoing now. So if you're looking to get involved with that in your region, you'll find information on each of the Thrive Together regional leads on our website. Next slide, please. So this project, slightly different one. This is one of our transformational projects. So partnering with the Castleback Club of Wounded Veterans, the Scar Free Foundation was awarded £300,000 to do a big piece of work on understanding and alleviating the impact of conflict-related genital scarring and loss of function. They're using that grant to develop interventions to diminish the shame and the stigma and embarrassment that can surround those injuries, and to empower current and future veterans to have fulfilling intimate relationships post-injury. This, as a transformational grant, this is a grant that's going after a really wicked problem. It's what our CEO always calls them, and it's such a strong example of that transformational programme of work. It's a very neglected issue, so their goal is that through pioneering and collaborative research, they're going to create some tailored psychological support tools for these veterans. Next slide, please. Final one I'll just flag, just because it's a project that really recently launched part of its work out in the world, thanks to a grant to Age Cymru Dyfed and Age Cymru Wales. In July, they launched a pioneering new e-learning course, which has been designed with older veterans to improve support to them. Takes 45 minutes to complete, available in English and Welsh, and has UK-wide scope though. And ultimately, it's about reducing hospital readmissions, tackling loneliness and sort of strengthening community ties by giving professionals understanding and tools to spot and support older veterans more effectively. And there's lots of information about that new course on Age Cymru Dyfed's website. Next slide, please. This is my last slide, but it was just to kind of flag, if you're listening with a project idea which perhaps aligns with the priorities of our strategy and you're working with voluntary sector partners on it in your area, that's where so much of the magic for patients can happen, in those collaborations. Keep an eye on our programmes page on our website. That's where you'll find everything you need to know about programmes that are open for applications and their eligibility criteria. We also have a newsletter you can sign up to, where you'll find reminders of closing dates and new funding opportunities. And there's just fantastic learning and evidence to come out of the collaborations that get made through grant funding. So we are always looking forward to what's coming next. Thank you very much for having me.
Claire, thanks ever so much for that sort of hectic gallop through what you guys do, actually. I mean, it's absolutely incredible. And sorry, just picking up on the e-learning in Wales, I have done that, actually. It's a really good package, and I've got some ideas that I might steal. So, no, thank you very much. And can I say your hair looks fine to me, but I mean, what do I know? Anyway, right, moving on before I get into trouble. So, I've previously called our next speaker a big hitter. Please welcome back Nicky Murdoch, MBE. She continues to drive inclusivity, change, and maybe more importantly, holds us all to account. Nicky is independent chair of NHS England's Armed Forces Patient and Public Voice Group. With 30 years of army service and extensive leadership in the Armed Forces welfare sector, Nicky brings a vital patient and family perspective. Nicky, over to you.
Thanks, Guy. Morning, everybody. Oh no, afternoon, everybody. Guy, thank you for inviting me to speak. And what a fantastic morning that highlights so much positivity and progress that I've seen over the last sort of 8 years in this role. And this morning, I just want to talk about a theme that has endured this morning around partnerships and collaboration and co-production, which are all words bandied about and not always followed through. But I think what I'm heartened to hear so much about is that this really is working. So what I would like to talk about today is the embedding of patient and carer voice and lived experience in the new NHS, because it's been a very difficult and challenging time, I think, for everybody, actually, across our society and across our community, but also for the NHS, for defence, And it's right, I think, that we should acknowledge that as a whole. But we've had, over the last years that 8 years I've been chairing this group, the opportunity to really ensure that patients and families and carers' voices are heard. And what I'd like to do is use my time today to talk about how we can raise that bar even higher. For those of you that don't know me, I have had 30 years in the army, which I loved. I had breast cancer, which took me out of the system for 2 years. I was treated fantastically by the NHS. I came out of the military and became the Chief Executive of Defence Medical Welfare Service, and delighted to see a brilliant video at the break on what they have been doing. I've also been a trustee at the Veterans Foundation. I currently chair a small brain injury charity in Dorset. And just to keep my hat in with the serving population, I'm also a trustee at the Royal Corps of Army Music. So a broad base, I guess, for this role, keeping me in touch with veterans, reservists, families, and carers. Next slide, please, Anne-Marie. I know that everybody, and Dan Brooks will put a little thumbs up here, knows about statutory responsibilities, and all the public sector has huge statutory responsibilities. But in the context of the overall NHS, there is this requirement to ensure that they consult with patient groups and the public. My observation would be that actually that tends to happen quite a lot when they're about to close a service or diminish a service. But actually, the NHS policy is very clear about involving patients and the public in any aspect of healthcare. And I should say here that the devolved administrations also have that requirement. They just do it slightly differently, but it's all there. And of course, the lucky thing that we have that supports our entire community is the Armed Forces Covenant. And Kate Davis talked about it as a theme, a golden thread running through this. And we are really lucky to have that, quite rightly, but it does support everything that's been done over the last 10 years, which is fabulous. And a huge amount has been achieved. Next slide, please, Anne-Marie. Again, gathering the sort of information, intelligence, and anecdote that I've seen over the last 8 years, this slide encapsulates really the key points of what everybody wants to see from their perspective as members of the armed forces community. And it's about mobility, it's about navigating the complicated NHS system, which has been constantly changing, let us face the fact. And one of my observations would be that sometimes the public sector isn't very good at marketing. They do their engagement, but their marketing and communications is what's really important for everybody to understand what system is there to do and what services are available and what those systems are actually called. And, you know, we're moving from ICBs, integrated care boards, now to clustered ICBs. That's what they're called this week, I think. It may change because there's such an awful lot going on. And I think, again, as a result of all the great work that's been done with partners and organisations, the National Training and Education Programme, which Guy's talked about this morning, I think will be a huge benefit, not just to the NHS, but also to the armed forces community. And I could echo what Tim and Deborah and Guy have said. about the quality of this team. It really is brilliant, with a great balance of staff. So I'm really looking forward to it, and the patient voice group has been embedded in their activity from the outset. Next slide, please. Talking of embedded, I just put this slide up here because although there is a requirement for patients to be involved and consulted, one of the things that I think is different about the Armed Forces Patient Voice Group is that actually they've applied the policy that exists really effectively by embedding us with the team as equal partners. So we've got the commissioners in the Armed Forces team, the clinical reference group under H's leadership, and then we've got the patient and public voice group. And we work as partners together. And what we've done, which is again in the policy, so everybody should be doing it, is we've asked to be engaged early in any programme of work, that we get an explanation of the context in which we're operating. And probably the key thing is enough time to understand the issues with an opportunity for transparent and continual feedback. And what that has meant is we've been able to contribute and add value to the commissioning team as the process of new change has come into play. And I think that's been really important. And I say that because that's what I'm trying to educate more broadly, as I'm asked by integrated care boards to help with the hearing of the Armed Forces voice in their patient consultation. And it is interesting that it's looking to the Armed Forces team for help about how to set up an effective partnership. And that's what we've been able to achieve here. Just the next slide, please, Anne-Marie. I've talked about the business of embedding, but I think key to hearing the patient voice is the preparedness of the Armed Forces team to actually listen really deeply to what's being said, and to be prepared to be challenged, because not everything that we feel about it, and Sarah highlighted it beautifully in her opening presentation, is easy to hear. So the preparedness to be challenged takes courage, and a preparedness to take risk, which we've seen from the Armed Forces team all the way through the time that I have been involved. And I guess for an organisation that is driven by activity and can be fairly impatient, the action on what's been heard is really important. And what it's done for us, it's built mutual trust between the team, the clinicians, and the patient voice group. And it's really helped us change the narrative. And we've done that by having a group of people with lived experience or who are experts in their field, made up of patients, families, and carers. But we've also been able to secure additional support and resource from Andrea Collins and the comms team to actually get involved with the communications and the marketing, rather than just the sort of slightly one-dimensional engagement activity. Moving on to the next slide. And I note Laura Robbins in the chat has made an observation about the hearing of the bereaved. Let me assure you, Laura, that we have representation on the patient voice group of those who've been bereaved and bereaved by suicide. So we've captured bereaved family members on the lived experience group. And we have about 40 patient voice partners who've been with us quite a long time, and it's allowed us to develop them into really good expert patient voices. And then we've enlisted experts in their field like Ali Brown, who leads on female veterans and LGBT. And you can see a smiling face there of Sue Lightbird, who has added significant expertise, both clinically and from her own personal lived experience. So the list of people that we've got there is represented across the group. And as you've heard me say, we are really lucky that we are listened to. And again, this has been a different way of doing patient voice that isn't always done across the NHS as well as it could be. The application of it can be patchy, but I'm really fortunate in the role that I have to be able to influence particularly the strategic level in the transformation of NHS England and its move to become part of DHSC, where I am able to involve the Armed Forces patient voice influence alongside some of the other independent chairs who have responsibility for mainstream NHS services. So again, very lucky. And with the group, what we've tried to do, and I'm stealing Sue's words here, but our community is not a monolith, it's not homogenous, and patient-centred care is really important, but we need to consider intergenerational activity, the intersections that exist, and how the group is evolving. And I'm very pleased that we've had a young person who's grown up living with a dad who has complex PTSD from Northern Ireland, and she adds excellent value to our group from a different perspective. So we've tried to capture all of the types of groups of people in our patient voice group. So what's been achieved? Next slide, please, Anne-Marie. We've heard about this today throughout, and all of it's been done in brilliant collaboration and partnership. And Kate alluded to the military maternity partnership. She talked about the single point of contact for complex cases, just to highlight one particular area, which again gives me absolute confidence that the Armed Forces team are in touch with patients on a daily basis. And Ellen Martin and Debbie King do brilliant work responding to need for complex cases, such as serving personnel coming back from overseas with healthcare needs themselves, with children with healthcare needs, and getting them back to the right place at the right time with the right level of support clinically and from a social perspective too. Excuse me. So there's a really huge amount of work that is being done and that has been delivered, which is fantastic. And again, working with the Forces in Mind Trust, working with the Armed Forces Covenant Trust Fund, the impact of what the patient voice group has done in highlighting gaps has been significant. And we've had an absolute abundance of research gone into for women who have served and are serving. And I was delighted to see yesterday that the Armed Forces Covenant Fund Trust have given DMWS some money for serving women and the provision of counselling. So, you know, the highlighting of issues and gaps that exist for our community is really working, and we've had support from the MOD, we've had support from the Office for Veterans Vets, and absolutely legendary support from the third sector. So it really is, frankly, to die for in the context of collaboration that the wider NHS would aspire to. So well done, and thank you. Next slide, please. Raising awareness, which is part of the section I've been asked to do, and I've touched on this in terms of things already, but it's great to see that we've got a consistent approach to naming conventions, which was started back with the patient voice group speaking to Johnny Mercer when he was the minister. And that's clearly had an ongoing effect, which I think has been quite positive in identifying things that are for the armed forces community. I'm really delighted to see that funding and activity in the devolved administrations is going really well and being supported, because actually we have got a UK armed forces, and we need to make sure that we haven't got, just because health has devolved, disadvantage or health inequality. And again, I think that's really important to be seeing across the whole community. Next slide, please. You've heard Kate talk about what will happen going forward, the new direction, the 10-year plan, the opportunities, and the 3 shifts. Next slide, please. And I make no apologies for just repeating the 3 shifts, because they're really important for us to understand. And that brings me on really to where I think we need to perhaps play our part alongside the charity sector, the statutory sector, the independent sector. And it's quite difficult when, as the armed forces community, most everything about our lives is provided for us when we're serving. And therefore, the shock of capture back in Civvy Street can be quite difficult to navigate and manoeuvre. And so I just wanted to sort of highlight the need for us as individuals, as part of the community, to do our own analysis of what we might need to do to look at the changes that are happening in the NHS. So next slide, please, Anne-Marie. I think the first thing we need to do as individuals is to know what the issues are. And I'm sure you'll get a copy of the slides which will confirm what we've assessed as what could look like. But actually for the serving community, and I know there's a huge amount being thrust upon the serving community all the time, but we do need to recognise that the medical system in secondary care, for example, needs to know that we are serving. That means taking ownership of our own healthcare, and I would say that's probably one of the strongest recommendations and bits of advice that I would give. The specialist referrals around the need for occupational fitness, which is the driver for fast track NHS support or clinical intervention. The need for continuity of care. I've touched on returns from overseas, but I've also touched on the business of assignments in different parts of the UK. But we should really understand that there is patient choice about where you are operated on if that need exists. And everybody, all of us, whether we're veterans, reservists, serving, families and carers, need to understand that the Armed Forces Covenant applies to the whole of the Armed Forces community, not always recognised, I would say. And I think for veterans, knowing what is out there for you is really important. Comes back to my point about marketing, but ownership of your own healthcare and knowing what is out there will help you to get to the place you need to be. And the other thing that I would urge everybody to understand is that not every service that we commission, such as Restore, Nova and Courage, is, you're not going to get a specialist service for everything. So it may be, and I say this as a cancer survivor, the best service may be a mainstream NHS service or pathway. And I think that's really, really important for us to understand, because sometimes we look for specialist stuff because we're comfortable and we're familiar with it, but actually the NHS has got some damn good services and we should be jolly glad to get into them. So again, I just urge every one of us to make that that point and recognise it. Next slide, please, Anne-Marie. My penultimate slide is really about what I think each of us as individuals, whatever our experience, can do to get involved. And we're not going to be spoon-fed this. The armed forces community is diminishing in size. We know that. But it's great that the armed forces commissioning team will continue. Patient voice will continue to be a statutory requirement. We know that the patient voice group will change. We don't know quite how yet, but I will be heavily involved with it. We can influence integrated care boards, integrated care partnerships by getting involved and understanding that we need to see that the armed forces voice is heard in the NHS at every level. We can't just expect the patient voice group to be the voice of the community. And getting involved in patient participation groups in primary care can really help us understand the NHS. Unfortunately, I would say that patient engagement groups, patient voice groups, citizens' assemblies are not always called the same thing, which isn't always helpful. And actually, if I'm absolutely honest, trying to identify who the patient voice lead is in each area has provided a challenge for the Armed Forces commissioning team as well as myself. But if you can have a look at it in your integrated care area, then you can ask to get involved. And I tell you, people will snap your hand off. And again, volunteer roles in hospitals as champions can really help get the armed forces voice heard at every level. And I think it's really important that we take ownership of that and get involved and not wait for it to come to us. So my final slide is basically patient voice in the new NHS. Be curious in your neighbourhood. You've heard the 3 shifts and the move to community, and you will hear the word place and you will hear the word neighbourhood. Be curious in your own area. Listen to what's going on and understand there's wider issues than just the armed forces, but learn about it. Get embedded in there. Don't be afraid to challenge, and ensure that people are responding to that challenge and acting on it. Thank you, Guy, for inviting me to speak. I hope that's been useful, and jolly good to see you all go to lunch. Thank you.
Thanks, Nicky, and bang on time, actually, 2 minutes over, but that's great. Yeah, I think, you know, on behalf of everyone here and indeed the armed forces community, Nicky, thank you to you and your team for all that they do for the armed forces community. Hugely impressive, and of course that training and education piece, you know, the team have been critical to the sorting out of the product, which has been impressive. So we now move to lunch. Can I have everyone back at their laptops or computers at 13:45, please?